So we're going to be talking about diabetes in this chapter, and this is chapter 24 in Med-Surg. Our priority concepts in this chapter are going to be, of course, glucose regulation. We're going to talk a little bit about nutrition, tissue integrity, sensory perception, immunity, fluid and electrolyte balance, and acid-base balance. So where is insulin made? Of course, it's made in the pancreas, and where specifically in the pancreas is the islets of Langerhans beta cells. The pancreas also has alpha cells that produce glucagon, okay? So what happens is the pancreas releases proinsulin, and then it travels to the liver where a peptide chain is broken off and it becomes activated insulin, which travels to the target cells to provide glucose for fuel. After you eat, carbohydrates break down into glucose, and that's a sugar that's the primary source of energy for your body. Glucose then enters the bloodstream. The pancreas responds by producing insulin, which allows glucose to enter the body's cells to provide energy. So we've talked a million times about insulin being the lock that opens, the key, that opens the lock of the cell to let the glucose in. So after you eat, when insulin levels are high, excess glucose is stored in the liver in the form of glycogen, and it's being saved there for times when the blood glucose drifts down, okay? So between meals, when insulin levels are low, the liver releases glycogen into the bloodstream in the form of glucose, and this kind of helps to keep your blood sugars level within a narrow range. So they kind of balance each other out, the insulin and the glucagon. And glucagon is just really a hormone that counteracts the actions of insulin, and it stimulates the liver again to produce glucose, and that's how it increases the blood glucose level. So in the absence of insulin, when there's no insulin at all to open the cells and let glucose in, we're going to have high glucose levels in the blood, which is hyperglycemia. We're also going to have signs and symptoms like polyuria, polydipsia, and polyphagia. When we don't have enough insulin, or the receptor sites are just resistant to the insulin, we do have to start with these certain symptoms. So polyuria, that's the increased amount of urine. You've got to go all the time. And when you have diabetes, excess glucose builds up in your blood. Your kidneys are forced to work overtime to try to filter and absorb the glucose. And when your kidneys can't keep up, the excess glucose is excreted into your urine, dragging along fluids from your tissues, and this will make you dehydrated. So dehydration is a major problem in hyperglycemia, and this is why we have polydipsia. They're really thirsty all the time because their cells are dehydrated. Also, polyphagia, because glucose isn't entering the cells. You may have a high glucose, but your body still thinks that it's hungry because your cells are starving. There's no glucose inside the cell. And when the body perceives no energy source, then it triggers hunger to fix the problem. So insulin stimulates glucose uptake, which promotes the storage of glycogen. And overall, insulin keeps blood glucose levels from becoming too high and helps keep blood lipid levels in the normal range. So in the absence of insulin, the body turns to stored fats for energy. So the breakdown of these fats by the liver creates ketone bodies. So this is usually not a problem for most organs because they can use these ketone bodies or the breakdown of fat as a source of energy, but it is a problem for the brain. The brain likes glucose as its energy source. Now, after 4 or 5 days, it can use the breakdown of fat or fats as its energy source, but it takes a while for the brain to switch over to these ketone bodies for energy. Ketone bodies are usually removed by the kidneys, but if the kidneys are overwhelmed with the high rate of ketone body production, like I said, the kidneys are just overwhelmed and they cannot keep up, and these ketone bodies build up in the blood. So, just to recap, ketone bodies can be used for energy. But the tricky thing about ketone bodies, they only can be used for energy if the proper intermediaries are present. And that just means that there has to be something in there that helps those ketone bodies be used for energies. And these, unfortunately, usually come from the breakdown of glucose. But in diabetics, there's very little glucose has been broken down, because they don't have insulin to break it down, right? So this means that even though the ketone bodies cannot be used for energy, could be used for energy, they can't because there aren't any mediaries to help them along. Okay, so they start to build up in the body. They're not being excreted by the kidneys, and they're not being used for energy. So this causes a sudden and severe ketoacidosis. Diabetes is often diagnosed by the smell of acetone, or that rotting fruit smell in the person's breath. It's highly acidic, and their urine is laden with acetone. So these signs indicate severe ketoacidosis and could be life-threatening. Luckily, a dose of insulin will allow the blood glucose levels to drop, and those intermediates required will start to be created from the breakdown of glucose, and the ketone bodies will be cleared out of the system in a short time. Okay, so to recap, without insulin, we have hemoconcentration because of dehydration. Dehydration means all of the water is out, so all of the contents of the blood are concentrated. You have hypovolemia, again, because of all of the water being out. We have hyperviscosity. That just means the blood is thick because it doesn't have enough fluid in it. It's just got the cells. So it isn't able to freely flow through the arteries, and the arteries can become blocked. So we will be, and if the arteries become blocked, that means you're not perfusing areas well with blood, and they become hypoxic. So we'll be giving our diabetic patients just copious amounts of fluid. Excess acids caused by the absence of insulin increases hydrogen ion and carbon dioxide production, and this causes what we call an anion gap metabolic acidosis. So you'll see metabolic acidosis on the patient's ABGs, and that means their pH will be below 7.35. Their CO2 will probably be low because their body is triggering them to breathe fast and deep. That's the Kussmaul respirations, to try to fix that acidosis and keep all of that CO2 blown off. So your pH is going to be low, your CO2 is going to be low, and then your bicarb, which is the metabolic component, is also going to be low. Okay? So we've talked about acidosis and potassium levels before. Acidosis can elevate potassium levels early on with insulin depletion. But it can also cause low levels. So depending on where you are with hydration, where you are with the acidosis, and how the patient is responding, potassium can be high, it can be low, or it can be normal. But it is definitely one of the electrolytes that's super important to monitor, okay, especially in ketoacidosis. All right, so complications of diabetes, you can have macrovascular and microvascular disease. That means just disease in the big vessels and the little vessels of the body. You can have retinopathy, which is vision problems, and that's because of this microvascular problems. You can have nephropathy or kidney dysfunction and neuropathy. Especially if you have any one of these, you are definitely at high risk for cardiovascular disease, especially if you're smoking and have a family history. So, how will you know that you have kidney dysfunction? Of course, we'll follow that bun and creatinine, but you will also start to see protein in the urine. So if you have some of those previous things that we mentioned, you're probably going to have cardiovascular disease as well. The American Diabetes Association recommends that the blood pressure be below 140/90 with a target of 130/80 if we can get it there. Okay? They need to have their lipid levels checked at the initial diagnosis of diabetes and every 1 to 2 years after that. Even if diabetes is not present, we need to be checking as a screening tool at the age of 40 for high lipid levels. Okay, so your ideal LDL, which is your bad cholesterol, needs to be below 100. And if that patient has cardiovascular disease, we want it below 70. Okay, they need to report signs and symptoms of dyspnea, sudden onset of nausea and vomiting. And remember that diabetes patients are 2 to 4 times more likely to have a cerebrovascular disease than other patients. Okay, hypertension, hyperlipidemia, nephropathy, peripheral vascular disease, and remember that alcohol and tobacco further increase the risk for stroke. All right, so that microvascular complications, those little vessel complications, eye and vision complications, so we need to be sure that our patients are having an eye exam regularly once a year. Legal blindness is 20/200, and diabetic patients are 25 times more likely to have legal blindness than other people. You can also have blocked retinal blood vessels, which causes them to leak, leading to retinal hypoxia. You can have edema, which are hard fatty deposits on the eye, and you can also have retinal hemorrhage, as well as optic nerve atrophy because it's not getting a blood supply like it needs to. There are medications that you can inject into the vitreous of the eye monthly to help macular edema, and one of them is ranibizumab, and then aflibercept or Eylea are those two drugs. Cataracts are also more common in diabetics, so again, we need to encourage those yearly eye exams. So diabetic neuropathy, what happens is you have some cardiovascular autonomic neuropathy, which affects the sympathetic and parasympathetic nerves of the heart and the blood vessels. And this problem contributes to left ventricular dysfunction. You can also have a painless myocardial infarction. These diabetics can. And so when a person comes into the emergency room with some odd or strange symptoms, you might suspect a silent myocardial infarction or a silent MI if they're diabetic. Okay, they can also have exercise intolerance. So, GI, in the GI tract, GI autonomic neuropathy can occur as well. And if that happens, you'll have reflux, delayed gastric emptying, and gastric retention. Heartburn, they'll be easily satiated when they eat. They may have anorexia or overgrowth of bacteria in the gut, which causes bloating, gas, and diarrhea. So when diabetics have diarrhea, it can be chronic and it can be severe, but most likely they're going to have constipation. because of gastroparesis or delayed emptying of the GI tract. This can also cause hypoglycemia due to a mismatch of insulin production and nutrient absorption. Urinary problems from neuropathy results in incomplete emptying and urine retention, and therefore UTIs. So nephropathy, diabetes is the leading cause of end-stage renal disease. This is related to a long history of diabetes with poor blood glucose control, uncontrolled hypertension, and also genetic predisposition. So what we do is we give ACE inhibitors or angioreceptor blockers to protect the kidneys. So ACE or ARBs to help protect those kidneys. So we talked about albumin being secreted in the urine. You might also see a decline in that glomerular filtration rate. Okay, sexual dysfunction can happen with diabetes as well. That's because of damage to both the nerves and the vascular tissue. And males can have erectile dysfunction or retrograde ejaculation, which just means that the semen enters the bladder instead of emerging through the penis during an orgasm. Although they can still reach a climax, they will only be ejaculating a very little bit of semen. And this is sometimes called a dry orgasm. Retrograde ejaculation isn't harmful, but it can cause the males to be infertile. So women can have vaginal dryness and pain with sexual intercourse and decreased libido. Diabetic patients are also at high risk for cognitive dysfunction like dementia and neuron damage resulting in brain atrophy. Metabolic syndrome is also called Syndrome X. It's classified as a simultaneous presence of metabolic factors known to increase the risk for developing type 2 diabetes and cardiovascular disease. So these factors are things like abdominal obesity, hyperglycemia, hypertension, and hyperlipidemia. Metabolic syndrome often occurs before the onset of type 2 diabetes, and it's often accompanied by cardiovascular risk factors of hyperlipidemia, hypertension, and increased clot formation. Type 1 diabetes. Type 1 diabetes is autoimmune, and like most autoimmune diseases, there's some question as to exactly how it happens. But what happens is the beta cells are destroyed by the body itself in genetically susceptible patients, and it can be triggered by viral infection like mumps or Coxsackie virus. Type 2 diabetes is one of the two major types of diabetes, and it's the type in which the beta cells of the pancreas provide insulin, but the body is unable to use it effectively because the cells of the body are resistant to the action of insulin. Although this type of diabetes may not carry the same risk of death from ketoacidosis, it otherwise involves many of the same risks and complications as type 1 diabetes, in which there is a total lack of insulin. So in type 2, you can have a decreased production of insulin and resistance at the cell level. Okay, and we just talked about that metabolic syndrome. So for health promotion, we want to make sure that we help the patient control their diabetes and any complications. That's our major focus for health promotion activities. We need to teach about a low-calorie diet, increasing physical activity, weight loss, keeping their blood pressure under control, lowering their triglyceride levels, and increasing good cholesterol, which is your HDL, and lowering bad cholesterol. Okay, so you need to look at the chart and know it pretty well. 64-1 at the bottom of page 1288. That's chart 64-1 at the bottom of page 1288. If you're older than 45 and overweight, you should be screened for diabetes. If you are under 45 and overweight and have some other problems like hypertension that put you at high risk, you should also be screened for diabetes. Okay? For fasting blood glucose level, a couple of readings over 126 are indicative of diabetes. Look at that chart. And then oral glucose tolerance test, it gives you the readings there. So as we go through with diabetes, we want to make sure we're checking their glycosylated hemoglobin assays, which that is just your hemoglobin A1C. The A1C test measures the percentage of hemoglobin proteins in your blood that are coated with sugar. Okay, that's what glycated means. Okay, so glycosylated means coated with sugar. So it's going to look at the hemoglobins that are coated with sugar. Okay, because hemoglobin is carried on red blood cells, this goes along with the life cycle of the red blood cell. So it gives you an average over the last 3 months because the life cycle of the red blood cell is 120 days. Okay, so if you're working with a patient and you're changing their medications and you want to see how they're doing before 3 months, you can do a glycosylated serum protein and albumin test. And this is called a fructosamine assay. And it checks that glucose that binds to amino groups on serum proteins, especially albumin. You can also do urine test, and what you're looking for there is protein and glucose spilling over into the urine, and test for kidney functions like the bun and creatinine. Okay, look over and study that concept map on page 1290. There's a lot of good stuff there. And then let's skip over to page 1305, and we're going to talk about peripheral neuropathy management. Okay, let me get over there in my book. That's page 1305. I'll get there in a second. Okay. So, whenever we're doing this foot assessment, we're going to use a monofilament, and you can use something like a nylon monofilament or or a cotton ball if you need to. Ask the patient to close his or her eyes during the test and test that monofilament on the patient's cheek so he or she knows what to expect, and then test the sites noted in this picture. Okay? Apply the monofilament at a right angle to the skin surface and apply enough force to bend the filament using a smooth, non-jabbing motion. The approach, contact, or removal of the filament at each site should take about 1 to 2 seconds. And apply the filament along the perimeter and not on an ulcer site. So if they have an ulcer in their foot, or a callus or a scar or any kind of necrotic tissue, you don't want to use that filament on there. Do not slide the filament across the skin or make repeated contact at the test site. And make sure that you randomize the sequence of applying the filament throughout the examination. Okay, and then have the patient identify where the filament touched rather than asking, do you feel this? Because a lot of times if you just ask, do you feel this, they will say, oh yeah, I feel it, when they really don't. So ask them where they feel it. Okay, so the priority collaborative problems for patients with diabetes include potential for injury, potential for impaired wound healing, and I guess we thought it was really important because we put potential for injury there again. And remember that the potential for injury is not just due to the fact that they have neuropathy and have a hard time feeling, but also, you know, if their vision is impaired, you need to make sure the area around them is safe for them. So good lighting, no throw rugs, that kind of thing. Okay? We have to treat their pain that's due to diabetic neuropathy, and think about the kinds of meds that you would give for that: gabapentin, Lyrica, those kinds of meds. They have potential for kidney disease, so we're going to have to keep an eye on those kidneys. Potential for hypoglycemia. Think about the signs and symptoms that you know for hypoglycemia. We'll go over that a little bit more in a minute. They have a potential for diabetic ketoacidosis, which we've talked about, producing those ketone bodies and getting into an acidotic state. They also have a potential for hyperglycemic hyperosmolar state and coma. Okay? So hyperosmolar hyperglycemic state is a metabolic complication of diabetes, and it's characterized by super high blood sugars, like greater than 600. They also will have extreme dehydration, hyperosmolar plasma. They'll have an altered consciousness. So it's really a very serious condition, and it's caused by extremely high blood sugar levels. It most often occurs in type 2 diabetics. So diabetic ketoacidosis is usually in type 1 diabetics. HHS is usually in type 2 diabetics. Both are often triggered by an illness or an infection. Okay? And in HHS, your body tries to rid itself of that excess blood sugar by passing it into your urine. And left untreated, diabetic hyperosmolar syndrome can lead to life-threatening dehydration. Okay? So look at the table 64-13 on page 1313. And it gives you an idea of what you'll see in diabetic ketoacidosis and what you'll see in HHS. And you need to really know this very well as far as the onset, the precipitating factors, the symptoms, and then all of those lives there and how they compare one to another between those two diabetic problems. Okay, so we need to prevent injury from hyperglycemia, and often we do that with medication therapies. It might be insulin, but it might also be oral medications. Oral medications are most often given to type 2 diabetes because a lot of them work with what you have left of your pancreas function to help produce more insulin, or they work at the cellular level to help the cells be more receptive to that insulin. Okay? So nutritional considerations. So in your carb intake, you need to focus that on vegetables, fruits, whole grains, legumes. You need to make sure that you're having some dairy products in there, usually low-fat dairy products. And the patient needs at least 25 grams of fiber to help move that peristalsis along. We want to avoid concentrated sugars, even if it's natural sugars like maple syrup. Okay? As far as fat and cholesterol go in the diet, focus on a high-quality fat, so mono unsaturated fats, nuts, seeds, olives, dark chocolates, omega-3 fatty acids, and fish or fish oil, and of course limit trans fats, saturated fats, and cholesterol. With alcohol consumption, if they drink alcohol, you want to teach them about moderate use, no more than 2 alcoholic beverages a day, and they should be ingested with a meal. The thing about it is, a lot of times there are different ideas about what constitutes an alcoholic beverage, one serving. So that's 12 ounces of beer, so you can have 2 12-ounce beers a day, 5 ounces of wine, 1.5 ounces of distilled spirit. And then you also, when you're creating a meal plan for these patients, you need to revolve it around the patient. What kinds of food they like to eat. What is their culture like? That kind of thing. So be sure and read over chart 64-4 concerning exercise. Okay? Pancreatic transplants can also happen. We need to prevent any injury from peripheral neuropathy, so make sure and clean and inspect those feet daily. Wear proper fitting shoes. Avoid walking in bare feet. Trim the toenails properly, straight across. Okay? Report non-healing breaks in the skin. Look in your book and know what a Charcot foot is and what causes it, okay? Shoes should be 1/2 to 5/8 inches longer than the longest toe, and they should not wear heels that are greater than 2 inches high, okay? So as far as socks goes, they should have no thick seams or creases or holes in the sock. They should pad the foot and absorb excess moisture. Be really, really familiar with foot care instructions on page 1307. We want to teach them how to get their blood glucose in line and how to avoid extreme fluctuations and prevent chronic neuropathy. Okay, but if they do have neuropathy, we have to manage their pain, and a lot of times we can do that with gabapentin, pregabalin, SNRIs like duloxetine, some tricyclic antidepressants like amitriptyline and nortriptyline. Okay, capsaicin cream, which is made out of peppers, can also be used. But it takes several days for that to work. So if they use that, they need to continue to use it for up to a week at least before they'll know if it works. Okay. We need to make sure they have regular eye exams and proper environmental control like lighting, contrast. You might use color codes for their medication bottles. Big print on the medication bottles. You might wrap a rubber band around the fast-acting and slow-acting insulins. Kidneys, keep a check on those urine protein levels, INOs, bun and creatinine, serum electrolytes, and maybe use an ACE inhibitor or an ARB, like we talked about earlier, to protect those kidneys. We need to encourage aggressive control of blood glucose and hypertension and smoking cessation, because smoking also injures the vessels. So you get a double whammy if you've got on your vessels if you've got diabetes but you also smoke. We want to avoid nephrotoxic drugs like antifungals and aminoglycoside antibiotics and NSAIDs. Okay, monitor their IV hydration before and after contrast, especially if they're on what drug? Metformin, right? We're going to stop it before and after, but we're going to make sure we flush those kidneys as well. Okay, on page 1309, you've got signs and symptoms of hypoglycemia. Let's look over there on page 1309. Okay. Symptoms of hypoglycemia. There are neuro kinds of symptoms there. So make sure you're very familiar with those. And then the causes, down there at the bottom, the right-hand corner, too much insulin compared to the food intake. Insulin injected at the wrong time relevant to food intake and physical activity. The wrong type of insulin injected at the wrong time. Decreased food intake resulting from missed or delayed meals. Delayed gastric emptying from gastroparesis. Decreased liver glucose production after alcohol ingestion. Increased insulin sensitivity as a result of regular exercise and weight loss, and decreased insulin clearance from progressive kidney failure. Okay? Let's see, where are we? So, preventing DKA, how will we know? They'll have uncontrolled hyperglycemia, metabolic acidosis, and increased production of ketones. We need to monitor the patients really closely during times of stress and monitor and treat their infections, because infections are the leading cause of DKA and HHS. You need to know the classic symptoms like polyuria, polydipsia, polyphagia, rotting fruit odor to the breath, vomiting, abdominal pain, dehydration, weakness, confusion, shock, and coma. So what are our goals? Let's look at page 1313 to the left. In that first column, we need to maintain blood glucose levels within the prescribed target. We need to make sure that insulin given matches our patterns of eating, especially during illness, and make sure that we continue to give our insulin even if the patient is sick. We have to maintain easily digestible liquid diet containing carbohydrate and salt whenever nauseated, and have them be able to describe the correct procedure for urine ketone testing, because that can help them know when they're about to get out of whack, okay? And make sure you teach them when to seek help from their healthcare professional. All right, here is the video. I'm going to put these little links in Brightspace so that you'll have them, okay? There's 2 videos. This is the second video, which talks about DKA versus HHS. They put an N in there for this one, but it's the same thing, okay? Again, I'll put those links in Brightspace. Okay, so patient education, you need to educate them on insulin storage. Most of the time the insulin's going to go in the fridge. Make sure you read up on that. Dose preparation, syringes, only use the orange diabetic insulin syringes. Okay, how to monitor and when to monitor their blood glucose levels, and any kind of infection control measures, and diet therapy. Okay, we've got a 23-year-old with a history of type 1 diabetes is admitted to the ED with nausea and abdominal pain. His respiratory rate is 34, and he is taking deep breaths and has a fruity smell to his breath. He's responsive but difficult to arouse. Okay? What does the nurse suspect is happening with this patient? What do you think? Diabetic ketoacidosis, right? What's our clues? Kussmaul respirations, fruity smell to the breath, difficult to arouse. What serum glucose level would the nurse expect to see with this patient? From anywhere from 250 to 500, okay? All right. The student nurse asks why the patient is breathing so rapidly and deeply. What is the nurse's best response? His serum pH is high, and this is a compensatory mechanism. His serum pH is low, and this is a compensatory mechanism. His serum potassium is high, and this is a compensatory mechanism. His serum potassium is low, and this is a compensatory mechanism. Okay, so we know that patients with DKA are acidotic, diabetic ketoacidosis. So the serum pH is low. So the answer is B. In the ED, the patient is diagnosed with diabetic ketoacidosis. We thought so. What's the nurse's first priority for managing this condition? Are we going to look at their airway, the administration of insulin, fluid and electrolyte correction, or administration of IV potassium? Okay, even though in the videos you're going to find that one of the very first things you're going to do is give them fluids, because this patient is unresponsive, we have to make sure their airway is assessed first. Okay, so the answer is going to be A. Okay, 20 minutes later, the patient is admitted to the ICU for DKA management. The patient is receiving IV regular insulin, which regular insulin is the only insulin that you can give IV, with frequent finger sticks to check his glucose level. So if they're on an IV drip, they should be getting Q 1-hour blood glucose checks. His potassium level is 2.5. Uh-oh, that's too low. And IV potassium supplements have been ordered. What assessment must the nurse make before giving the IV potassium? Respiratory rate of less than 24, production of at least 30 mL per hour of urine, level of consciousness and orientation, or finger stick blood glucose of less than 200. It's going to be production of at least 30 milliliters an hour of urine. Okay, before you give a potassium rider, you need to make sure that their output is okay. Otherwise, you're just going to swing that potassium from 2.5 all the way up to 6, okay? 2 days later, the patient is recovered and preparing for discharge. His wife asked about what they can do to prevent this from happening again. What should the nurse teach the patient and his wife? Should we monitor glucoses whenever the patient is ill? Yeah, that sounds good. So A. Can we decrease fluid intake when nausea and vomiting occur? No, we don't need to decrease fluid intake because dehydration is going to be a problem. Watch for and report any illness lasting more than 1 to 2 days. Yes, that's true because illness is one of the things that can make you have ketoacidosis or kick a diabetic over into ketoacidosis. Check blood glucose levels every 4 to 6 hours if anorexia, nausea, or vomiting is experienced. And remember, they're at home now, so yes, every 4 to 6 hours. If they're actually diagnosed with DKA and they come into the hospital, then it's going to be every 1 hour, okay? Check urine ketones when blood glucose is greater than 300. That's true too. So the answer is A, C, D, and E. Okay? A nurse is teaching a group of patients about metabolic syndrome. Which assessment features are associated with the syndrome? Male waist circumference of 44 inches. Yes, that's true. Fasting blood glucose of 66. No, that's low, right? Triglycerides values of 162. Yes, that's true. Blood pressure of 135 over 85. Yes, that's true. Our goal is 130 over 80. Patient is taking blood pressure medication, and that's true as well. So the answer is A, C, D, and E. Those are all associated with metabolic syndrome. When caring for a patient having a hypoglycemic episode, the nurse knows which symptom requires immediate intervention: hunger, confusion, headache, or tachycardia. It's B, confusion. Glucose is necessary for the brain function. The brain likes glucose best. So confusion is a marker of severe hypoglycemia, and that requires immediate intervention. Irritability, anxiety, hunger, tachycardia, headaches, sweating, and seizures are also signs of hypoglycemia. Yeah. The nurse is teaching a patient with type 1 diabetes about exercise. The nurse understands the patient should avoid exercise during what time? During colder months, when serum glucose is less than 150, when ketones are present in the urine, or when emotional stressors are high for the patient. Okay, it's going to be C, when ketones are present in the urine. Exercise should be avoided if ketones are present in the urine. Ketones indicate that the current insulin levels are not adequate, and that exercise would actually elevate blood glucose levels. All right, anti-diabetic drugs. This is chapter 32 in your pharm book. So insulin, what does it do? It has a direct effect on fat metabolism. It stimulates lipogenesis. Lipogenesis is the formation of fat, the metabolic formation of fat, and it inhibits lipolysis. So lipolysis is the breakdown of fats and other lipids by hydrolysis to release fatty acids. So it promotes intracellular shift of potassium and magnesium into the cell. So that means in the blood, the potassium is lowered, as is the magnesium. So those are two electrolytes that we probably definitely want to watch. Okay, and And just know that cortisol, epinephrine, and growth hormone also work together with glucagon to counteract the effects of that insulin. Diabetes. So signs and symptoms. An elevated fasting glucose over 126 or a hemoglobin A1C of greater than 6.5. Polyuria, polydipsia, polyphagia, glycosuria, that means glucose in the urine, unexplained weight loss, fatigue, and blurred vision are all signs of hyperglycemia. Type 1 diabetes. There is a total lack of insulin production in type 1 diabetes. So they are prone for diabetic ketoacidosis. They list HHS here as well, but it is actually more likely to happen with type 2 diabetics. Okay, so with DKA, hyperglycemia, ketones in the serum, acidosis, dehydration, electrolyte imbalance, okay? With HHS, there's more extreme dehydration and confusion. It's usually diagnosed by blood tests that show very high levels of glucose in very concentrated blood. So treatment is going to be IV fluids and insulin. And complications can include a coma, seizures, and even death. So type 2 is the most common type of diabetes, making up about 90% of the cases. And it's caused by insulin deficiency as well as insulin resistance. We've talked about this before, but many tissues are resistant to that insulin. Type 2 diabetes has a lot of comorbidities like obesity, coronary heart disease, dyslipidemia, hypertension, microalbuminemia, increased risk for thrombotic blood clotting events. And these comorbidities are collectively referred to as metabolic syndrome, also known as insulin resistant syndrome or syndrome X. And these can often, the metabolic syndrome often comes about before you develop type 2 diabetes. Gestational diabetes, this is where you have high glucose during pregnancy. Insulin has to be given. They do not take oral medications at this time. Even if they were taking oral medications for type 2 diabetes before they became pregnant, they will be switched over to insulin during pregnancy. Okay, and it's found that many of gestational diabetes will develop type 2 diabetes within 10 to 15 years after their pregnancy. So a woman who has type 2 diabetes is now pregnant. She wants to know whether to take her oral anti-diabetic medication. What instructions will she receive? She could continue the anti-diabetic medication at the same dose. The anti-diabetic medication dosage will be increased. She will be switched to insulin therapy, ding, 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 while she's pregnant. She will not receive any anti-diabetic medication while pregnant and will need to monitor her dietary intake closely. So it's C. Type 1 always requires insulin because they don't make any. Type 2, however, there are some non-pharmacologic treatment interventions that can help, like weight loss, improved dietary habits, smoking cessation, reduced alcohol consumption, and regular physical exercise. All right, so our goal, the glycemic goal for treatment is going to be to get that A1C at 7, okay? So a normal A1C is less than 5.7. Some references say 4 to 6. If you get above 5.7, though, you're starting into pre-diabetes, okay? But greater than 6.5 is indicative of type 2 diabetes. Your fasting blood glucose goal for your diabetic patients is anywhere from 70 to 130. So we don't want it too low or too high. Treatment for diabetes type 1, you have to take insulin, lifestyle changes for type 2, and oral drugs. And eventually they may have to be on insulin when oral drugs and lifestyle changes no longer provide glycemic control. Insulin, oral hypoglycemics are some things that we're going to use, and there are some new injectable hypoglycemic drugs that can be used in addition to insulin or anti-diabetic drugs. Insulins, they function when we give them just like the insulin that the body makes. They're gives the diabetic patients the ability to metabolize carbs, fats, and proteins to store glucose in the liver and convert glycogen to fat stores. So, let's talk about the types of insulin. This is rapid-acting treatment for type 1 and type 2 diabetes. Okay? Its onset is 5 to 15 minutes. Its peak is 1 to 2 hours. And let me just tell you, Dominique, I know that this is mainly for you that I'm recording this. So there is a table in your med-surg book, and that is the one that I want you to go by as far as knowing and it's on page 1295, as far as knowing the insulins, their onset, their peak, and their duration. Okay? I'm going to send you, or I'll put it here in Brightspace, or yes, here in Brightspace, a copy of the form I gave everybody that they can use to write out their onset, peak, and duration for the different insulins that I want you to know. There is one insulin that I did not put on the list that I really would like for you to know. And when we get to it, I'll tell you that this is the one that you need to put on your list, okay? Each of these slides has some bolded statements to really kind of pull out some things that are important about those particular meds, okay? So for rapid acting, the patient must eat a meal after the injection, okay? You can give these sub-Q, and they can be given by a pump sub-Q, but they cannot be given IV. Only regular insulin can be given IV. Okay, this is the one I want you to add, Dominique, aphresa, okay? Write all this information down about it. You need to give it within 20 minutes before each meal. It needs to be given in conjunction with a long-acting insulin or oral diabetic medicine. The side effects are hypoglycemia, but also cough and throat pain because it is a powder that's inhaled. It's contraindicated in smokers and those with chronic lung disease because it can cause bronchospasms, and that's why it has a black box warning. Short-acting insulin is just your Humulin R, regular insulin. It can be given IV infusion, IM, or sub-Q. Insulins can come in U100, U200, U300, and U500. And these are just the concentration. So the standard is U100, okay? But insulin pens can be either U200 or U300. And then U500 is a really concentrated insulin that they use an insulin pump sometimes, especially for patients that need high doses of insulin. All right, so NPH is your intermediate acting insulin, and it's the only one that should be cloudy. Okay, and make sure that on your little list that I give you that you put in there all of the onset, peak, and duration that's written in your med-surg book, not what's written here, but in your med-surg book on page 1295. Long-acting insulins. These are your Lantus, your Glargine, okay? And these are basal insulins, and it gives a constant level of insulin in the body, okay? Levemir or Detamir can be given once a day even in higher doses. And there's an ultra long acting one, which is Tresiba. You see here. Okay, the nurse has just administered the morning dose of the patient's Lispro, which is Humalog insulin. Just after the injection, the dietary department calls to inform the patient care unit that the breakfast tray will be late by 45 minutes. What will the nurse do? Just tell the patient about the delay, check the patient's blood glucose level, call the dietary department to send a tray immediately, or give the patient food such as cereal, skim milk, and juice. You're going to give them food. Okay, Lispro insulin's onset of action is 15 minutes. It's essential that a patient with diabetes eat a meal after injection. Otherwise, profound hypoglycemia may result. Okay, when you have combo insulins, just know that you should not mix these with any other kinds of insulin. Each contains two different insulins in fixed combination. One is an intermediate acting insulin, and the other one is either a rapid acting or a short acting. Sliding scale insulin. You're going to have sub-Q or rapid acting Lispro, Aspart, or short acting like regular insulins that are adjusted according to the blood glucose test results. Okay, these are typically used in hospitalized diabetic patients or those on TPN or enteral tube feedings. Sub-Q insulin is ordered in an amount that increases as the blood glucose increases. We've all seen sliding scales. The disadvantage is that it delays insulin administration until hyperglycemia occurs. So it's not really preventative, and it results in large swings in glucose control. Basal bolus insulin dosing. This is the preferred method of treatment for hospitalized patients with diabetes because it mimics a healthy pancreas, because it delivers a basal rate of insulin or a constant low rate of insulin. Then we do boluses as needed, and that's how your body works. Okay? Oral anti-diabetic drugs used for type 2 diabetes. Their effective treatment involves several elements. Okay, we have to watch those blood glucoses. We are going to do maybe one or even two drugs, maybe more. Treatment of associated comorbid conditions also have to happen, like high cholesterol and high blood pressure. Okay, so for new onset type 2 diabetes, lifestyle interventions are what we're going to start with. And then we're going to add metformin as the first drug. We're going to give that for 3 to 6 months before we think about adding anything else. Okay? Metformin or glucophage, like I said, is the first line drug, and it's the most commonly used oral drug for the treatment of type 2 diabetes. It is absolutely not used for type 1 diabetes. Biguanides work by decreasing the production of glucose by the liver, because, you know, the liver, whenever blood glucose levels start to drop, produces that glucose to help keep the glucose in balance. So these drugs decrease that, and it also decreases intestinal absorption of the glucose itself. And it increases the uptake of glucose into the tissues, which leaves it. Okay, so metformin is your example of this medication. A lot of its problems are GI problems like abdominal bloating, nausea, cramping, diarrhea, and feeling of fullness. But you can also get a metabolic taste in the mouth and reduced vitamin B12 levels. Okay, so lactic acidosis is rare, but it can occur, and it can be lethal if it occurs. But metformin does not, again, cause hypoglycemia. Glimepiride, which is Amaryl or glipizide, these stimulate insulin secretion from the beta cells of the pancreas, and that's how it increases insulin levels. So you have to have a functioning pancreas, and these are sulfonylureas, okay? So your beta cell function in the pancreas must be present. This improves sensitivity to insulin in the tissues, and it results in lower blood glucose levels. unfortunately does have some adverse effects like hypoglycemia. So you can get hypoglycemia from sulfonylureas. It can have some hematologic effects, nausea, epigastric fullness, heartburn, and many others. Okay, the glinides. These are drugs like repaglinide and teglinide, and you see they all in glinide. Okay, they also increase insulin secretion from the pancreas. So you can get headaches, hypoglycemia, dizziness, weight gain, joint pain, upper respiratory infection, or flu-like symptoms with the glinides. Okay, glitazones like Actos and Avandia. These are insulin sensitizing drugs, which just means they make the cells more sensitive to the insulin and allows it to unlock the cell in those patients who are insulin resistant. So it decreases insulin resistance. It's called the insulin sensitizing drugs. And what it does is just increases glucose uptake and use in skeletal muscles, and it inhibits glucose and triglyceride production in the liver. Adverse effects are going to be flatulence, diarrhea, abdominal pain. They do not cause hypoglycemia or hyperinsulinemia or weight gain. These are the alpha glucosidase inhibitors. Okay, the alpha glucosidase inhibitors. These are like Precose or Glycit. Okay, the thing to know for sure about them is you don't give them to patients with inflammatory bowel disease or any kind of malabsorption syndrome or intestinal obstruction. So the adverse effects are GI. Okay, flatulence, diarrhea, abdominal pain. Very rarely you can have hypoglycemia. And if they do have hypoglycemia with this particular drug group, they don't respond to carbs. So you have to give IV or oral glucose to fix hypoglycemia with Precose or Glycit. These are alpha glucosidase inhibitors. Okay, so how do they work? They inhibit the enzyme alpha glucosidase in the small intestines, and this results in delayed absorption of glucose. These have to be taken with meals with the first bite of a meal. Okay, so that can be a really good NCLEX question, right? So I would be sure and know that about alpha glucosidase inhibitors, the first bite of a meal. Okay, so dipeptidyl peptidase IV, DPP IV inhibitors, okay? Gliptins are what they're called a lot because the generic terms all in gliptin, okay? Sitagliptin, okay, that's Januvia, okay? So what they do is they delay breakdown of the incretin hormone by inhibiting the enzyme DPP-IV, okay? So incretin is a gut hormone that happens minutes after eating, and it's one of the many physiological roles that regulates the amount of insulin that's secreted after eating. So if you give one of these inhibitors, your goal is to reduce fasting and postprandial glucose concentrations. Okay. The side effects or the adverse effects, you can get upper respiratory tract infection, headaches, and diarrhea. Hypoglycemia can occur and is more common if it's used in conjunction with sulfonylureas. Okay, So oral antibiotic drugs indications. We can use them alone or in combo with other drugs. We need to use them with diet and lifestyle changes as well in patients with type 2 diabetes. So there are some injectable anti-diabetic drugs. There are amylin agonists like Simlin. There are incretin mimetics like Byetta, Trulicity, Victoza, and then there's some combo agents down there. Amylin agonists, they mimic the natural hormone amylin. Okay? And amylin is a hormone that's produced by the pancreas and released at the same time as insulin, but in smaller quantities. It assists insulin in controlling post-meal glucose levels. Okay, so it does centrally, which means in the brain, modulates appetite and fullness, or being satiated. Okay. And these are usually used when other drugs have not achieved adequate glucose control. They're given by sub-Q injection. Incretin mimetics, they mimic the incretin hormone and enhances glucose-driven insulin secretion from beta cells of the pancreas. It's only used for type 2 diabetics. And exenatide is an injection pen device that is an incretin mimetic. Amylin agonists, the adverse effects, nausea, vomiting, anorexia, and headache. Incretin mimetics, nausea, vomiting, and diarrhea. It can cause rare cases of hemorrhagic or necrotizing pancreatitis and weight loss. Okay, sodium glucose cotransporters, SGLT2 inhibitors. Okay. The way it works is it increases renal glucose excretion, so it helps you pee off more sugar, okay? It works independently of insulin to prevent glucose reabsorption from the glomerular filtrate, okay? Which in turn results in reduced renal threshold for glucose and glycosuria, or getting rid of that glucose in your urine or through your urine. It can increase insulin sensitivity and glucose uptake in the muscle cells and decrease glyconeogenesis. So this improves glycemic control. It helps with weight loss, and there's a very low risk of hypoglycemia with these drugs. So hypoglycemia, this is an abnormally low blood glucose level, below 50. But we need to start watching our diabetics at about 70, okay? And be thinking about getting them something to eat pretty quickly. Mild cases can be treated with a diet. You're going to have a higher intake of protein and a lower intake of carbohydrates to prevent rebound postprandial hypoglycemia. So hypoglycemia, early signs are confusion, irritability, tremors, sweating. Late signs are going to be hypothermia, seizures, coma, and death can even occur. Glucose elevating drugs, you're going to have those buccal tablets that are semi-solid gels, which is just concentrated glucose, and you put those in the buccal mucosa. You can also give 50% dextrose or D50, and you can give glucagon as well, IV, IM, or sub-Q. After giving drugs that alter your glucose level, we have to make sure we have a thorough history, we have some vital signs, a blood glucose check, and an A1C level, and know all of our potential complications and drug interactions. So before giving drugs that alter glucose level, make sure we know if our patient can consume food, because if they have a hypoglycemic response, we want to be able to treat it quickly. Okay, assess for nausea and vomiting. Hypoglycemia may be a problem if anti-diabetic drugs are given and the patient does not eat. If a patient is NPO for a test or procedure, make sure you ask the PCP to clarify any orders for anti-diabetic drug therapy and if they want to give those or not. Keep in mind that overall concerns for any patient with diabetes increase when the patient is under stress, has an infection, has an illness or trauma, and is pregnant or lactating. Okay, a patient with type 1 diabetes is admitted to the medical unit with an acute exacerbation of chronic obstructive pulmonary disease. He's placed on an IV piggyback antibiotic, nebulizer treatments with albuterol, and an IV corticosteroid. He's also taking a PPI for gastroesophageal reflux. He takes a dose of glargine insulin every evening. This evening, the nurse notes that his blood glucose level is 170. The next morning, his fasting glucose level is 202. What's the most likely cause of his elevated glucose levels? Is it the albuterol, the antibiotics, the proton pump inhibitor, or the corticosteroid? It's the corticosteroid. It antagonizes the hypoglycemic effects of insulin, resulting in elevated blood glucose. Okay, so thorough education is always important. We need to teach about the disease, about diet and exercise recommendations, about insulin or oral drugs, and any potential complications from both your disease process and drugs. When insulin is ordered, we want to make sure we've got the correct route, the correct type of insulin, the correct timing of the dose, and the correct dosage. Insulin ordered and prepared doses are always second checked with another nurse. A lot of you got graded harshly if you did not put that in your video ATI thing. Check it with another nurse, always. Insulin. You have to check those blood glucose levels before giving it. Roll the vial between the hands instead of shaking them. Make sure we have the correct storage of insulin vials and only use insulin syringes calibrated in units to measure and give insulin, not TB syringes. Okay, so never use a TB syringe. Always use an orange insulin syringe to give insulin. Make sure you have correct timing of insulin doses with your meals. So you don't want to get your insulin doses off away from your meals, because if you do, you're going to have some hypoglycemic episodes in your patient, which can be really dangerous and scary. Okay, when drawing up 2 types of insulin in one syringe, always withdraw the regular or the rapid-acting insulin first, okay? So we're going to put our air into the cloudy, our air into the clear, which is regular or rapid-acting. Remove the clear or draw up the clear and then go back and draw up the cloudy. Make sure that your patients are thoroughly educated about self-administration of insulin, including when they should give it, how much they should give, how they monitor their blood glucose levels, and injection site rotations. Super important, because if you get scarring in an injection site, your absorption of the insulin is going to be way decreased in that area. After the 0700 report, the day shift nurse notices that a patient has an 0730 dose of insulin due and goes to the automated dispensing machine to retrieve the insulin. The nurse sees that the night shift nurse had removed the 730 dose of insulin, but the medication administration record has not been signed by the nurse. The patient is confused and says she thinks the nurse gave her the insulin. The patient's blood glucose level is 142. What will the day shift nurse do? Give the insulin because it was not signed off? Hold the insulin because the patient thinks she received it and it is recorded in the machine? Ask the charge nurse to call the night nurse at home to clarify whether the insulin was given, or report this to the nursing supervisor. We're going to call her at home. See. Never ever guess whether a drug was given. Taking the drug out of the machine does not mean it was given, so we have to ask that night nurse what was done. Okay, so nursing implications for oral anti-diabetic drugs. Always check blood glucose levels before giving, usually given 30 minutes before meals. But the alpha glucosidase inhibitors are given with the first bite of each main meal. Okay, metformin is taken with meals to reduce GI effects. And remember to discontinue that metformin if the patient is to undergo studies with contrast dye because of the possible renal effects. So we need to check with the prescriber about that. Okay, we need to always assess for signs and symptoms of hypoglycemia. If hypoglycemia does occur, administer oral forms of glucose if the patient is conscious. If the patient give the patient those glucose tablets or gel, corn syrup, honey, fruit juice, or non-diet soft drinks, or have the patient eat a small snack such as crackers or a half sandwich. We want to deliver D50 or glucagon IV if the patient is unconscious and monitor those glucose levels because you may have some rebound hypoglycemia. Monitor them for a therapeutic effect. That means we're going to monitor those blood glucose levels. We're going to monitor our hemoglobin A1C and monitor for hypoglycemia and hyperglycemia. So a male patient who has a history of type 2 diabetes is admitted to the medical unit with the diagnosis of pneumonia. The patient has many questions regarding his care and asks the nurse why everyone keeps telling him about hemoglobin A1C. What can the nurse inform the patient about the use of hemoglobin A1C in diabetes? It helps to identify which type of diabetes the patient has. It will identify if he has an infection. It will aid in monitoring patient compliance with treatment regimen for several months previously. It represents current fasting blood glucose levels. So hemoglobin A1C is going to be C. It helps tell if they've been compliant because it tests several months previously. Okay. The patient was taking metformin before his hospitalization. To facilitate better glucose control, the patient has been switched to insulin. Okay. The patient asked the nurse why it is so important to time meals with the insulin injection and to give him an example of a long-acting insulin. Which drug will the nurse tell the patient is a long-acting insulin? Okay, which one of these is a long-acting insulin? C. So the timing of the meals with insulin and oral anti-diabetic therapy is important to prevent hypoglycemia and to obtain the most optimal results from the anti-diabetic therapy. Detamir is a long-acting insulin. Glulisine is a rapid-acting insulin. MPH is an intermediate insulin, and of course regular insulin is short-acting insulin. The patient is being discharged home with insulin aspart, Novolog, and insulin isophane suspension, MPH. Which information does the nurse include when providing discharge teaching to the patient? Store the insulins in the refrigerator. Shake the insulin for 1 full minute before using. Administer the insulin at a 30-degree angle to your skin. Draw up the insulin aspart first and then draw up the insulin MPH in the same syringe. D. So we have to do the clear and then the cloudy. The nurse enters the patient's room to complete the discharge process and finds the patient to be lying in bed unresponsive and breathing. The patient has a blood glucose reading of 48. What's the most appropriate response by the nurse? Place a pack of table sugar in the patient's mouth, start CPR, roll the patient to the side and administer the ordered glucagon, or have the patient drink orange juice. I think it's going to be C, yes. Glucagon is a natural hormone secreted by the pancreas. It's available as a sub-Q injection to be given when a quick response to severe hypoglycemia is needed. Glucagon can induce vomiting, so we're going to roll that unconscious patient onto his side before the injection. Okay?